International Women's Day is celebrated annually on March the 8th to commemorate the achievements of women. And this year's theme is Break the Bias. As a passionate advocate for women's health, I am marking this International Women's Day by spotlighting some of the excellent women's health focused podcasts my colleagues and I at FX Medicine have released over the last few months. Now, sometimes with so much great content out there, it's really hard to zero in on what the key takeouts are. But by sharing mine, I hope you'll learn something new and find additional ways to support women's health in your clinical practice. Here are the practice pearls from my top women's health podcasts so far. I hope you enjoy them. The first of our clinical pearls comes from the episode Let's Talk HRT, the sequence of the Women's Healthy Aging Study with Dr. Michelle Woolhouse and Professor Cassandra Surkey. One of my key clinical pearls from this podcast is the importance of a detailed case history in clinical practice, particularly for women's health. As practitioners, it's just imperative that we take notes of the signs and symptoms of our female clients and undertake an informed risk profile when developing a treatment plan, particularly when historically women had their symptoms brushed off as being hysterical and were often not even treated. From a practitioner's perspective, it just blows my mind to think that right up until 2016, all medical testing was done on male lab rats due to the complexity and variable nature of women's health, the inability to control these variables and how this may have impacted the outcomes for women's health when applied to women. It's just unbelievable. There's still so much that we can learn from the case-taking process, though. It's such an imperative part of the consultation. It's very therapeutic for women as well to feel heard. My second clinical pearl from Professor Cassandra Surkey is the importance of treating the signs of the menopausal transition, including the common things like hot flushes. Hot flushes are often ignored, with women grinning and bearing them without any treatment. But actually, hot flushes are increasing their risk of heart disease, and women often tend to sort of downplay their symptoms. We also know that severity of menopausal symptoms, such as hot flushes, is strongly associated with an increased risk of cardiovascular disease and a reduction in health later in life. So they're not to be ignored. Heart disease is the second leading cause of death in women in Australia, and cerebrovascular disease is the third. So being able to gauge these symptoms as practitioners and respond to them is really important. Finally, for my last pearl of this episode, at the end of the episode, Cassandra gave us her healthy aging tips. And the one that really stood out to me the most was when she was talking about meaning and purpose and connection to community and how essential it is for our quality of life. I really loved this advice, and we see it clinically all the time. And I love that Cassandra also pointed out that the meaning and the purpose doesn't have to be some big thing. It's the ability to just identify the things and the people that make you want to get up out of bed in the morning. Like for me, it's like Sophia, her happy little face makes me just want to get out of bed, and that's a purpose for me. And helping my patients every day is such a purpose for me. So to summarize again, make sure to assess menopausal symptom severity and take a really thorough case history. And talk to your patients about meaning and purpose in their lives at all stages, but particularly as they get older. My next set of clinical pearls came from the podcast that I did with Rhiannon Hardingham on interpreting hormonal pathology. There was so much I learned from this podcast. But let's take DHEA, one of my all-time favorite hormones. It's important to test this, as it's a reflection of a woman's adrenal resilience and her chronic stress levels. This is so useful in clinic to test. Now, it's a hormone produced by the adrenals, and then it's converted across into testosterone. Low levels correlate to the chronic stress picture and this progressive wear and tear on a woman's body. So working on improving levels of DHEA is absolutely critical. Rhiannon's key herb of choice here is Tribulus, taken daily for 3 months. The next one that also came from the podcast with Rhiannon was on estrogen dominance. Now, the gold standard assessment for estrogen dominance is 2 well-timed blood tests, one on day 2 or 3 of the menstrual cycle and one 7 days after ovulation during that peak luteal phase. So aim for between 100 to 200 on day 2 to 3 and then around 600 to 700 during the luteal phase. If a woman has an estradiol level over 700, for example, and her progesterone on the same peak luteal blood test is under 60 and she's exhibiting symptoms of estrogen dominance, then and only then can you say that she's estrogen dominant. So let's drop using this phrase unless we have clinical evidence for it with 2 well-timed blood tests. Thank you, Rhiannon, for those pearls. Another fantastic clinical pearl from the podcast with Rhiannon was the great Vitex debate, as I called it. Now, I bet this confuses so many clinicians out there. Now, you use Vitex when you have a low estrogen or low progesterone state. So, for example, premature ovarian insufficiency. Rhiannon also reminded us to think about those steroidal saponin-based herbs like shatavari, dong quai, and black cohosh for these low estrogen states. When do you not use Vitex? You don't use it if there's any evidence of estrogen dominance, like endometriosis, PCOS. The outcomes of prescribing Vitex in situations like this could be an exacerbation of those symptoms such as heavy periods, sore breasts, irritability, and I know from experience, a very cranky patient. So please ensure that you test for estrogen dominance before you use Vitex. My next set of clinical pearls come from the podcast I did with Dr. Nicola Gates, Menopause, Estrogen, and the Brain. The importance of estrogen in the brain is unbelievable. It's used in oxygen metabolism in the brain. And did you know that there are more estrogen receptors in that prefrontal cortex than anywhere else in the brain? I didn't actually know that. And this is the region involved in reasoning, problem solving, impulse control, and creativity. So the brain actually makes its own estrogen in the hypothalamus. It doesn't simply use systemic estrogen. That is how important estrogen is for brain function. My next little one is about what I call the multitask dilemma. So the type of estrogen we are producing impacts how our brain functions. And a great example of this is during pregnancy. So just to recap and remind you, estradiol or E2 is the most common type of estrogen in women of childbearing age, just the strongest one. Then we have estriol or E3, the main estrogen produced during pregnancy. And finally, estrone or E1, the only estrogen your body makes after menopause. And that's the weakest form of estrogen. And due to changes in the type of estrogen produced during pregnancy, we become better at toggling between tasks. That was Nicola's phrase, toggling, which sort of, I guess, sets us up for parenthood. But in modern day women, this toggling pattern means a woman thinks she can multitask, but in fact, she's simply overburdening herself with mental load. And you would see this clinically all the time, I am sure. So just remind her of those different forms of estrogen and how they work in the brain. The next one that Nicola brought up was, do I have dementia? Now, when the brain is adjusting to lower estrogen levels in menopause, it becomes not only harder to form memories, but also to actually retrieve memories. And it's critical to reassure a woman who thinks, have I got dementia at 55? Tell her you are forming those memories. It's the change in estrogen levels causing a change in the enzyme that helps you retrieve that memory. 2 separate things. And just remind your patient that this is a temporary situation that will pass once her brain adjusts to those lower levels of estrogen. So as Dr. Nicola Gates said, it's a temporary situation. I hope you've enjoyed all the clinical pearls in the podcast today, and I look forward to sharing more with you very soon. I would love to hear from you all as well. Let's work together as a collective to support each other in clinical practice. Post your best piece of health advice for women in the comments below. We can all learn so much from each other. So let's get the conversation going to support our practice and the women in our lives.